Listen, because thanks everybody for joining this evening. My name is Dr. Sata, and I'm a traditionally trained ICU doctor, but have switched primarily into functional medicine now because I feel like this actually has an excellent potential for getting people well in a way that is very different from what we see in the hospital. And so I want to share some of the things that I find really exciting about that. So I'm going to talk for a little bit, and then I'm going to introduce you to Laurel Brennan. She's a health coach and an occupational therapist who has been working with me, who's also trained in the RECODE protocol, which is the protocol from Dale Bredesen that's been shown to reverse cognitive decline in patients. And I just want to use this as an example of what's possible. I'm going to try to avoid getting too much into the weeds because I could honestly talk about this for several hours, and I want to leave some time for questions at the end, and we'll go from there. So, all right. So tonight, we're going to talk a little bit about the scale of Alzheimer's and the existing treatments and standard of care. We'll look at some of the limitations in the way that we typically think of medical research. And then we'll talk about some of what's been done with Dale Bredesen's work. He wrote The End of Alzheimer's, which some of you may have seen. We'll also talk about the Avanthia trial, which is a randomized clinical trial that is actually testing his theories in a prospective manner. Then the results from that, or an update on that, was released at a conference just last week, 2 weeks ago. We'll also talk about what it looks like if you really are trying to apply a precision medicine and a personalized medicine approach to patients, and then what potential next steps could be. So first, I think many of you are aware of this, but when we think about Alzheimer's, the scale of this problem is really hard to underestimate. There's about 1 in 9 people age 65 or older who have Alzheimer's disease, and that's over 7 million people currently in the US. And it's expected to continue to increase as our population gets older. And the expense of caring for patients and long-term healthcare costs for millions and millions of patients with cognitive decline and Alzheimer's is in the hundreds of billions of dollars. And this is data from the Alzheimer's Association. They're estimating $384 billion in costs. And so I think trying to see, is there another approach, is absolutely a worthwhile approach. When I think of the way that I was taught about Alzheimer's, I was always taught, this is part of aging. There's nothing you can do about it. It's not worth testing for because what are you going to do in the first place? And I actually went into Open Evidence last night, and this is a medical research tool that's linked to a lot of the updated articles and research journals. Now it's kind of our version of ChatGPT, but all with medical evidence. And when you look at the prognosis of Alzheimer's, they basically say it's progressive, irreversible cognitive decline leads to eventual continual functional disabilities and ultimately death. And that's a pretty dismal outcome or outlook when you're trying to figure out, well, what do you do about this? And as a country, we have spent billions of dollars investigating this. And since 1995, they estimated more than $40 billion looking into research for Alzheimer's. And we're really not coming up with a lot. These are the FDA approved treatments right now. And all the ones up in the top here that are in yellow are to treat some of the symptoms. But if you look here, the things that are supposed to slow the disease progression, that's just a couple of these down at the bottom. And note that they say slow disease progression. They don't say improve prognosis or improve your outcome, like help you think more clearly. Just let's slow this down a little bit. And that's what we've gotten for our $40 billion worth of research. Some of the most positive or the most promising results are looking at these anti-amyloid antibodies. And these are drugs that are designed to address the amyloid proteins that are produced in the brain. And just billions and billions of dollars has been directed towards amyloid because we know in patients with cognitive decline and Alzheimer's, they have more amyloid in the brain. And it seems to make sense. Well, if you could get rid of that amyloid, then maybe those patients would get better. And unfortunately, we're not seeing a lot of improvement. There have been 3 different drugs that have come out They're all close to $25,000 per year. And what they do is to slightly decrease the rate of decline. So nothing actually improves your cognitive function. It just slows it down by a little bit. And that's with, tens of thousands of dollars per person per year to get that slowed down. And I think some of this is a problem with the way that we do research, because we're constantly looking for a single bullet, a single drug, a single agent that's going to help address cognitive decline. And this is partly based on our medical history. When penicillin was discovered, this was absolutely a miracle drug. And if you were septic and had childbed fever and were potentially going to die from an infection, and then you got penicillin, that turned your life around, and it really was a magic drug. And so, oops, how did I get? I'm not sure how I got that. Sorry. So, and when we look at cognitive decline, it's not a single problem. It's a multifactorial problem. And so there are a lot of different conditions that can contribute to cognitive decline. And if that's the case, then we need to find, let's see, Sharon, it looks like you are coloring on my screen. I don't know how that's possible. But anyway, we need to find multiple treatments to address all of these different factors contributing to cognitive decline. And if we look at the way our research is set up, that's really not how we are doing it. Now, Dale Bredesen has written some really phenomenal books, and the first one is called The End of Alzheimer's. And this came out over a decade ago and was a #1 bestseller. And this was only published when we realized that he couldn't get funding from the conventional channels. He had looked to see what were the different factors contributing to Alzheimer's in a very benchtop research kind of way. And he felt like there were many, many factors that were all contributors. If you're only addressing one of those, that may be part of why some of those drug trials haven't been working, because they don't cast a broad enough net. And so he tried to get funding to do a broader trial, and that's really not the way the NIH is set up. And he ended up just going to the public and writing out his ideas in a book. And that's how things took hold. And then he was able to get private funding to try to advance this further. He has since demonstrated that his protocol, which is called RECODE, it's reversal of cognitive decline, that this is the only thing we've seen published that actually shows improvements in cognitive function. So this scale right here is a cognitive decline scale. And in here, they're showing you decline over time. And here you're showing actual improvement in cognitive function. So, and how do you do that? And what are the side effects? Because when we look at the side effects of the conventional medications, even these medicines that we think are the most promising medications, the aducanumab and lecanemab and donanemab, those are the anti-amyloid antibodies. They pull the amyloid off, but in doing so, they sort of uncover. It's kind of like pulling the scab off your knee if you skin your knee, and they uncover problems in the brain that can end up leading to brain bleeding or brain swelling, because typically the amyloid is only produced to try to protect your neurons from something else, whether it's heavy metals or toxins or infections or potential bacterial membrane pieces. It's called LPS, that are from bacteria in the GI tract that end up getting into the brain, and those can trigger amyloid formation. The amyloid's trying to wall that off to protect you. So ripping that off is like ripping off the Band-Aid. But if you haven't fixed the problem, that's potentially not helpful. Whereas when you look at this RECODE protocol, the potential side effects are things like improvement in your weight, improved strength and fitness, and blood pressure and blood sugar control of inflammation. And so in general, people are getting healthier because the protocol is really to support your overall health. I show this because one of the hardest things about treating cognitive decline is to convince people that it's possible. And when we think about Roger Bannister on the 4 Minute Mile, up until he broke that record, people really believed that it was impossible to break the 4 minute mile, that this was something that was not possible for humans, and we shouldn't even try because it's just not in the cards. And once he did it, once he proved it was possible, then many other runners after him have also been able to prove that that's the case. And in my mind, I feel like Bredesen's work of showing that some people actually get better is kind of that same idea of showing that you can break that barrier. And now we have to figure out, how do we do that? So if this is not, if this is true, many people ask, well, then why isn't this mainstream? I mean, we said we're spending billions and billions of dollars researching it. The cost to care for long-term care is so great. So if this really works, why don't we do this mainstream? And I think that's because of the way our research is designed. And medical research right now is designed so that you take a single intervention and you do a randomized placebo-controlled trial. So you have one group of people that gets the treatment, another group of people that don't get the treatment, and then you want to look and see what happens. And did the people who get the treatment do better overall? Like, did they get less cancer or less Alzheimer's, or did they recover faster from the flu? And you compare that group to your control group or your placebo group. And this is considered kind of the highest level of evidence. We have this pyramid of evidence-based medicine. And so at the bottom down here, we've got just expert opinion and what your general thought is. And then we have case reports and case series, cohort studies, which are just studies of large groups of people. And then we have randomized controlled trials, where you do those placebo controls. And then we just take all those randomized controlled trials. And if you have a whole bunch of them, like say there's 10 randomized controlled trials that look at statin therapy or aspirin or different things, then you start to combine them into higher and higher levels of systemic review. And this pyramid of evidence is considered, the definition of what is high quality medical evidence. And it sounds really good. Like, who wouldn't want evidence-based medicine? The problem with that is that it's only looking for the kinds of things that can be identified when you're manipulating a single factor or a very limited number of factors. And if you think of, some of you may have seen this cartoon before. You're talking about, the gentleman who has lost his wallet, and he's looking and looking and looking and can't find his wallet and can't find his wallet. And the policeman comes over and says, well, is this where you lost? And he said, no, but I lost it in the park over here, but this is where the light is best. And I feel like when we're looking for treatments for complex multifactorial diseases, and we're going to need a complex multifactorial treatment, then we've got to look over where those complex multifactorial treatments are. And that is not in this limelight where we see, as the analogy would go, where we see this single placebo effect. So I believe that our standard medical research model just isn't designed to evaluate these multifactorial protocols. And when you compare that to some of the research that's possible with a multifactorial approach, this is a pilot project. And this was by Dr. Kat Toops, who has been working with Dale Bredesen. Dale Bredesen is down here, and Anne Hathaway and Sharon Hausman-Cohen. And they've been working with Dr. Bredesen for many, many years in trying to find personalized ways to come up with treatment programs that help individuals. And I just want to walk through one of these studies, because I hear many times, is there research behind this, or is this all anecdotal? And there is definitely research behind it. Here we go. So this study looked at 25 patients who had dementia or cognitive decline. And they were evaluating in each patient for dozens of markers. And these were markers that looked at inflammation, dysbiosis, which is a change in the bacterial populations in the GI tract, protein glycation. So glycation just means attaching sugar molecules onto different proteins. If anybody's ever had a hemoglobin A1C checked to look at their blood sugar and any tendency towards diabetes or prediabetes, you're looking at glucose molecules stuck to hemoglobin. So that's glycosylated hemoglobin or hemoglobin A1C. And that's a marker, that glycosylation process, or like candy coating of the proteins, that happens to hemoglobin, but it happens to hundreds of other proteins as well. So it's not just the hemoglobin. They looked at sleep apnea, because if people aren't getting good oxygen overnight and they're not getting good quality restful sleep, that's going to interfere with their cognitive function. They looked at potential nutrient deficiencies, chronic infections, insulin resistance, vascular disease, and hormonal regulation, toxin exposure. And they're trying to check all of those things to optimize everything that they can. Then they looked at MRIs at baseline and then at the conclusion of the study, which was at 9 months. And they did multiple cognitive assessments at baseline and then at 3 months, 6 months, and 9 months. And you can imagine this is a lot of research. This is a lot of labs. It's a complex study to run logistically to get this much data. But they're showing very significant results. And these are biomarkers. And so if we look here, CRP is a measure of inflammation. Hemoglobin A1C is looking at insulin resistance, and that's that glycosylation protein, sugar-coated protein that I was just talking about. This triglyceride to HDL ratio and homocysteine ratio, both of those have to do with the risk of cardiovascular disease. Vitamin D, that's a specific vitamin D marker, which has a lot to do with inflammation and immune function. And they saw significant improvements over their personalized treatment approach in all 5 of these markers. Then MoCA scale. The MoCA is a form of cognitive assessment, and it's the scale that goes from 0 to 30. And what we expect when we have cognitive decline patients is that they will steadily get worse. That's the standard trajectory. People don't tend to get better. And what they're seeing from baseline over 9 months is that their groups continued to get better. And even just holding steady would be better than what you would expect. But they're actually showing an improvement, which is impressive. And then they asked the patient's partners. So, if you had a spouse who had cognitive decline, that spouse or that patient might not be able to assess how well they're doing, but their partner or their spouse is probably likely to. And 84% of the spouses felt like their significant other was getting better with this approach. When they looked at the MRI data, because you could argue that this is placebo effect, or that this is, people know they're in a treatment approach and they want to believe something's better. It's hard to want your brain to get larger. And so that's why they were doing these volumetric studies of the brain. And this is on MRI. And they looked at the total gray matter. And they found that there was an increase in the gray matter by 0.3%. Now, this was annualized over a year. So I told you the study was 9 months. So they just kind of prorated that to be what it would be if it was annualized to a year. And then they compared that to historical controls. And what we would expect for patients who don't have cognitive decline is that their gray matter is going to decrease by about 0.8 or 0.9. And for the patients who do have Alzheimer's, we expect it to decrease by between 2.2 and 2.3%. So instead of these decreases, we're actually seeing an improvement, which is unheard of. And if you look at Dr. Bredesen's book, when they originally were doing these studies, the radiologists did not believe that this was possible. And so they would go back and they would say, well, nobody regrows brain. Like, we must have read the original study wrong. And so they would go back and revise their original report, because you can't just say somebody grew a new head or has a third kidney or something and they don't grow a new brain. And so they ended up needing to blind the radiologists so that they could really document what was happening. They also looked at the hippocampus, and this is the memory center of the brain. And what you expect here for a patient who's cognitively stable, so no cognitive decline at all, you expect to see the hippocampal volume decrease by more than 1% per year, like 1.4 to 1.7%. And somebody who has cognitive decline, this is mild cognitive impairment, and this is Alzheimer's disease, so more severe, you expect that hippocampus or that memory center to be decreasing even faster, up to 3 to 4% per year. And in these patients who had documented cognitive decline, so they should have been down here in this group, their hippocampus was only decreased by 1.2% or 1.3. So that's better than the patients who were cognitively stable. And that is honestly unheard of. But I think it shows you that the body does have a tremendous ability to heal, and that includes the brain. There's another trial that the study that I just showed you did not have a control group. And so many people criticize that because there weren't any control arms. And it's hard to randomize somebody into a control arm that says you have cognitive decline and we're going to do nothing for you. But they have gotten funding now for the Avantia trial. And this is ongoing at the moment. This was presented at a conference 2 weeks ago by Dr. Kat Toops, who's the principal investigator. And the study advisor is Dr. Dale Bredesen. And what they've done is they have 72 patients enrolled, and 2/3 of their patients are going to go into the treatment group. 1/3 of the patients goes into the standard of care group, which basically means that we're just going to watch and wait and do nothing. And then after 9 months, the people that were in the standard of care group have the option to go back and get the treatment approach. And all of these patients have been enrolled. The study's ongoing. We don't have the results back from that, but this will be coming out hopefully soon. And I want to show you, so Dr. Christine Burke is on this as well. She's running a clinic out in California that's enrolling patients in this trial. And I've been working with her on a program to try to replicate what they're doing in this study at other centers. And so that will be coming out hopefully later this summer here. When I think about the model that we have in conventional medicine versus in an ideal world, like ideally, we would like to be able to customize treatments for everybody and know in advance what's going to work for them. In reality, there's an awful lot of trial and error, and there's a lot of side effects where you try something, see if it works, there's side effects, we come off of that, let's try something else. And then we look at what happens when you have a randomized controlled trial. So theoretically, the best form of evidence. And you take a large number of diverse people, put them into a trial, try to make them as uniform as possible. And that means that then you look for a result where you've really kind of muddied the water, because you can't tell if maybe there would have been a treatment that was perfect for the guy in purple, but not for everybody else. And you sort of lose that in this muddied mess of the results. And I feel like that limits our ability to find out what's going to work for a specific individual. And so randomized controlled trials just can't show us that, but there are other things that can. And this is where we talk about personalization and understanding the heterogeneity or what's different about people. So say you have a whole room full of a lot of different people, they're all exposed to the same thing, or say they all come in with cognitive issues and you're trying to understand what's different about one particular person. It's usually not just one thing. There's a whole bunch of different things about that person. So how do you figure that out so that you know what's the right treatment for this one versus this one versus this one? And that's when personalization comes through. Functional medicine is really helpful because it helps to look at what the underlying causes are. We can look at genomic testing. So what are your specific genetic weak points or genetic susceptibilities, and that may be different in one person versus another, and therefore it allows us to customize the treatments. for anybody who's here who's new to functional medicine, I want to let you know I had been in medicine for almost 20 years before I had ever heard of this term. And that was all through medical school and residency and fellowship. And this was a very new term for me. So if you haven't heard of this, then you're in good company. But when in traditional medicine, we typically start with trying to figure out what the diagnosis is for the patient. And, do you need to go and see a neurologist for your headache, or a gastroenterologist for constipation, or do you need to see the immunologist for frequent infections, or a pulmonologist for persistent cough? And so we're constantly looking at how do we treat all of these individual diseases, and who has the most or the greatest specialty in that area. And there really is a sense that, if I'm a generalist and I know that the cardiologist has more knowledge about all these cardiology things, I want you to have the benefit of that cardiologist. So I want you to go see him, because maybe he knows something I don't know. And maybe the GI doctor knows something that I don't know. And so in good faith, most doctors are going to send you to an awful lot of specialists to try to get as much information as possible. But that's ended up segregating a lot of our information. And so the cardiologists know a ton about cardiology, but they don't really deal with GI. And the same is true in reverse. And that's not really how the body works, because the body works as a whole unified system. So if we try to look in reverse and we say, well, what are the underlying things that need to work well to create the situation where people are healthy, then those are things like, can you absorb your nutrients well? Do you have enough energy and like cellular energy for your cells to function the way they're supposed to? Can you eliminate waste products the way you're supposed to? Do your cells talk to each other back and forth like they're supposed to? That can include hormonal signaling. It can include neurotransmitters. It can include cytokines. We look at the structural integrity of the body. So are the bones and the muscles doing what they need to? Are you transmitting forces through the fascia and through the musculature appropriately? Do the barrier functions in the body work, like the blood-brain barrier or the intestinal barrier? And those are all pretty fundamental. And so I like that approach when you're dealing with complex multifactorial diseases. This includes an awful lot of things that involve the patient. So instead of me as a physician prescribing you a new medication to control your blood pressure, that's me giving you something and then you just swallow the pill. That's kind of one-way treatment. But when we want to create health, it really needs to be a two-way discussion. And a lot of that responsibility rests with the patient. And that means the patient has a lot more ownership and control over what's going on. And as physicians, we're honestly not taught how to involve the patient in their own care so that they can get better. We're just taught that we're supposed to figure out what the treatment is. And I really like this approach. This is an approach that Dr. Christine Burke came up with. And she puts this specifically as verbs. So rest, and whether people are sleeping and taking time to relax and recover. To nourish, so to get the food and the nutrients that you need. Movement, and so exercise and general movement. Connection, and that includes social interactions and friendships. Grow, and this is challenging your brain, learning something new, like constantly expanding your horizons. And that sounds kind of aspirational, but that's what we need to be like healthy human beings. We talk about reflection, on removing any potential toxins, on trying to address the microbiome. And all of these are things that the patients and the families can do, and this can be done in community. And then we think about the medical factors. And so we've broken this up into 6 subsets of root cause for dementia. But this would apply for autoimmune conditions, for chronic conditions, for all sorts of things. So it's not just dementia, but you want to make sure that the metabolism is working well, nutrients and mitochondria are appropriate, that people have the hormones and the signaling they're supposed to, that their heart and their blood vessels are working the way they're supposed to, that you have the right bacteria in your GI tract, and that we address any potential toxins either coming from an imbalance in the gut or from other chronic infections or exposures, and then any potential chemical toxins, because this is a very different world we live in now than in 50 years ago. And with that, I wanted to transfer things over to Laurel Brennan. I had told you about her. She has some excellent experience applying these types of treatments with patients and getting the patient's buy-in. And so I will let her explain this to you.
Thank you so much, Dr. Satta. If those of you who are here tonight don't already know Dr. Satta, let me just share that she is my favorite doctor out there. She's so thoughtful and measured, as you can probably already see in her presentation, but just curious, and I feel very lucky to be affiliated and connected with her practice. So thank you, Dr. Satta. And this is me on the TED stage a couple of months ago, where I shared my own personal story, a diagnosis with multiple sclerosis, and my mom's diagnosis with dementia. So that's my mom. I talked about the functional medicine, which I was kind of accidentally introduced to by another mother at the bus stop when I got my MS diagnosis, and went down that path for me. And so I'm kind of looking at my mom's story now. She's no longer here, but she's continuing to teach me. And I went all the way back, which is what functional medicine does. It looks at your history as far back as your mom's health when she was pregnant with you. And, my mom was covered in eczema head to toe as a baby, had lots of environmental stressors. And then subsequently, when she got older, had a heart infection, which led to autoimmune disease. And none of these root causes were ever addressed. So after, years of these symptoms that were a result of the root causes not being addressed, she developed dementia. But now Dr. Bredesen has taught many people now how to reverse and prevent cognitive decline, which is my daily focus. So I'll share Tamara. So she obviously gave permission for this to be shared. She is a college professor who came to me with concern, not only about her multiple autoimmune diseases that kept layering. It was one diagnosis and then another autoimmune and then another autoimmune. But she was also feeling like her memory and concentration was declining. Physically, she had lots of pain in her joints and muscles. She had chronic allergy symptoms, just very weak, severe headaches, was sick all the time. That number at the top, that MSQ, that's a medical symptom questionnaire. And like in golf, we want that number to be low. She started off with a 60. And after we started addressing root causes, you can see just a few months later, it had dropped from a 60 to a 41. So her concentration had improved. Her headaches were totally gone. She still had allergies. So then we kind of dug a little deeper and found that mold was an issue. These are mycotoxins kind of under that toxin category that was mentioned. And then within a year, her MSQ was a 6. So as Dr. Satta mentioned, the side effects of the drugs, brain bleed and brain inflammation. Well, the side effects of addressing poor concentration or poor memory, the cognitive issues, are that everything else gets better too. That's exactly what happened. So still those remaining allergy symptoms, we kind of figured out that her mold exposure was in the work environment, that she was teaching a night class once a week, and we minimize that as much as possible. But you can see in a year's time, dramatic improvement. She was absolutely thrilled. And that's what can happen when you address root causes. So there's a case study for you.
Yeah, that's excellent, because I see people in the hospital a lot where they just get one new diagnosis after the next, after the next, after the next, and that can continue for years and years and years. Or you accumulate them, and the number of medications that you're on just is more and more and more and more to try to manage the symptoms. And it keeps putting more and more band-aids on the symptoms, but it doesn't actually address what's wrong. That's, you had mentioned eczema with your mother, and with this patient, and that's certainly one thing that we see all the time. When people have inflammation that's showing up in their skin, if you just rolled around in poison ivy, then maybe it's because of something on your skin. And so addressing it at the level of the skin makes sense. But most of the time it's from some sort of inflammation that's being triggered internally. And yes, you could put a steroid cream on the rash and it'll get better, but it doesn't address the internal inflammation. And so you just keep accumulating additional symptoms. So go on. So when we work with patients, we talk about a lot of different factors. And I think of these kind of as some of the things that get rolled into functional medicine, but it's just good medicine. It just happens to not have great lab results and tests that we can use in the conventional side. But we look at gut health. And so in a normal healthy gut, you want, if these are the normal healthy cells and you have stool up here and your bloodstream is inside of that, then you want to make sure that the barrier function of the GI tract is working. And that if there are toxins or metabolites or waste products or, the bacteria in your gut, that is not getting into the bloodstream. You want nutrients to get absorbed, but you don't necessarily want this to be wide open and then metabolites from stool to be getting into your system. And when people have inflammation, this barrier starts to get more and more permeable. So you're letting more stuff into the bloodstream, which can trigger inflammation. Say you have like a half digested food protein that gets into the bloodstream, then your immune system recognizes it as foreign. You produce antibodies against it, and then those antibodies can go and attack other tissues. So that can attack your thyroid and lead to autoimmune thyroid disease, and it can attack joints, and people get rheumatoid arthritis. And there are many, many patients who have experienced their arthritis gets better when they go on a gluten-free diet. And that's because of this connection between the GI tract and the bloodstream. Then we think of vascular health. And when people talk about the blood-brain barrier, that barrier is a vascular barrier. And so everyone has blood vessels going to the brain. If you didn't, you would all have strokes. And so we need to be able to get oxygen into the brain, but we don't want to be letting a bunch of other stuff into the brain that shouldn't be there. And so that's dependent on these capillary vessels having a solid barrier. And so that's where we get into a lot of vascular health. I'm not going to talk about that too much because I could spend an hour talking about vascular issues. We look at mitochondrial function because all the cells in the body have mitochondria. And whether that's the heart cells and you think of just how much energy that takes, or the neurons that are firing constantly, or the liver and kidneys that are constantly filtering your bloodstream, that's all dependent on mitochondrial function. But even your skin cells, which are nowhere near as active, they still need mitochondrial function. And we have certainly seen that neurodegenerative diseases, things like Alzheimer's and Parkinson's, are associated with dysfunction in the mitochondria in the brain. Then we look at toxins, and I show this picture because it's not about some absolute amount of toxins that you can tolerate or not tolerate. It's about what's the rate of exposure and what's the rate at which you can get rid of them. And some people inherently can clear toxins much more rapidly than other people. And so they could potentially tolerate a higher exposure and not have a problem. Other people are going to be more sensitive. But once you get to the point where you've overwhelmed your ability to clear the toxins, then they start to accumulate and end up kind of spilling over and causing more damage. And some of the damage that can be caused is that it basically inhibits the enzymes that should be working to clear toxins, and then it just becomes a self-perpetuating cycle. So that we want to address issues like that. Then we look at genomics. And Intellex DNA is really the company that I'm aware of that has pioneered this. And I had referenced a couple of articles that they have done. But they have a panel, they have a number of panels, but one that I wanted to talk about is this brain optimization panel that looks at hundreds of different gene variants that can contribute to disease. It doesn't mean that they are equal to what a disease. It's not like if you have this, you will definitely get Parkinson's or Alzheimer's, but it can impact the risk. And they look at genes related to brain ischemia. So ischemia just means not getting enough oxygen someplace. So if your blood is kind of too thick or prone to clotting, then you may have more problems with ischemia. They look at different genes associated with memory or hippocampal atrophy. That's the center of the brain that controls memory, white matter disease. And so that's also related to multiple sclerosis. They look at genes related to inflammation and sensitivity to gluten, detoxification on different nutrients that can be transmitted throughout the body. Like, yes, you want to have vitamin B12, but you also need to be able to transport that B12 across into the brain when you need to, and you need to have vitamin D in your body, but you also need to have vitamin D receptors, and you need to have those receptors in different tissues. And so there's a lot of individual things you can look at. And this is Dr. Sharon Houseman Cohen. She's the one who started all of this, and she has been interviewed all over the place. This was a fairly popular discussion with Dr. Mark Hyman about using this kind of approach in cognitive decline patients. These are a couple of the articles that they have published looking at outcomes when they use this sort of precision approach. And I just want to share one story that they presented last year at a conference in DC. And this is a case in Dr. Houseman Cohen's clinic. This is not my patient, and his real name is not Lenny, as you can potentially tell by the AI picture. But this was a 47-year-old gentleman who had come in because he's a businessman and had noticed that he just couldn't think well, especially when he was traveling. And they did some initial cognitive testing, and he's pretty young at 47 to start having cognitive issues. And the tests had shown mild cognitive impairment. And we think of Alzheimer's as a spectrum that can start up to 20 years in advance. And so he's already kind of further along on that spectrum than you'd want to be at age 47. And he had come across Dr. Bredesen's book and tried to implement some of those strategies. He put himself on a ketogenic diet. He started taking a bunch of supplements, and he really wasn't getting any better. So then he went in to try to get some more testing. And when they did his testing, this is an example of some of the results that you can get back. And this report is useful because it's giving you the gene, like the specific gene that they're checking, but it also is giving you the prevalence of that particular variant. And so in his case, he has one copy of a gene that affects blood clotting, but it's only present in 3% of patients. And so if you had a gene that affected blood clotting, but it's in 50% of patients, that's probably not going to be the thing that's causing his outcomes to be so different. But if this is present in just 3%, then that sounds much more suspicious. And that has to do with factor 2, which is one of the proteins related to the clotting cascade in the body. He had another gene variant that's related to factor 5, and that's only present in 5% of patients, and it is also related to blood clotting. And so both of these are going to make him more prone to forming blood clots. Now, that doesn't mean he's guaranteed to get Alzheimer's. And if he was in a car accident, that'd probably be a good thing, because he's probably less likely to bleed out from his car accident. But it does mean that if he's on a flight and up in an airplane at low oxygen levels and not getting up and walking around, that he might be more prone to some more blood clots that are forming. When you think about blood clots, think of, there's this like spaghetti and meatballs analogy. The meatballs are the red blood cells, and then the spaghetti are the fibrin strands that kind of knit all of the red blood cells together. And that's how you form a clot. And then these things that look like, they look a little bit like sea urchins. Those are supposed to be the platelets that also help to bring everything together. And in his case, this just happens much more. He's much more prone to this developing than the average person. This isn't significant enough to need to be on prescription blood thinners like Coumadin or warfarin or apixaban, but it is enough to think about his risk. And there are some things that you can do about this. So pycnogenol is a plant-based compound from French pine bark maritime. I think I'm saying those words in the wrong order, but pycnogenol is an antioxidant, but it also helps decrease fibrinogen levels by up to 62%. Lumbrokinase is another enzyme that helps to decrease fibrinogen, and it also decreases a lot of inflammatory cytokines. And they've actually done studies using lumbrokinase in China in patients who had recent strokes, and you're trying to prevent a second stroke. And they found that it decreased the rate of a second stroke by 82%. So it dropped it from somewhere around 5% to 1%. So that's a substantial improvement. And you have to assume that those patients that already proved that they could have one stroke are probably more likely to have another stroke, and also more likely to have, to clot too much, because that's probably partly why they had the stroke in the first place. Nattokinase is another enzyme similar to lumbrokinase, and it also decreases fibrinogen. And you can look up, there are trials on all of these. So there's a lot of evidence on all these different potential interventions. And so they went through his whole genomics, and I'm not going to go through all of it because it's a lot. But I want to show you the impact that it can have on customizing a plan. Because for him, I told you he had been on a ketogenic diet. And they can be wonderful diets, but they are not necessarily easy. And when they looked for him, they realized that he does not have some of the risks that we think of where ketogenic diets are so helpful. So if you have ApoE4, that's a gene that increases risk of Alzheimer's, but it also is really well treated by a ketogenic diet. He did not have that risk factor. And he didn't have mitochondrial dysfunction or problems with some of the genes regulating mitochondria. And so they decided maybe he doesn't need to be quite so strict on the ketogenic diet. And so they just said, how about just Mediterranean low carb? Doesn't have to be as difficult. But we do have to do something about that risk of clotting. And so they put him on pycnogenol and lumbrokinase. And then they also looked and they realized that he had a gene that affects his conversion of testosterone to estradiol. And even though this is a gentleman, everybody still needs some estradiol, which is a form of estrogen. And you have lots of estrogen receptors, especially in the brain. And so if he's not able to get the hormones regulated in the brain correctly because of this alteration in enzymes, then he may be particularly amenable to, or may benefit particularly well to supporting his testosterone. And so that's what they did. They put him on androgel, which is a form of testosterone gel. Then they also realized he had a gene that decreases his ability to transport B12 where it needs to be. So they put him on higher doses of B12. And then liothyronine is a form of thyroid hormone. It's the active form of thyroid hormone. And if you go into the doctor and you have low thyroid, most of the time they'll put you on Synthroid or liothyronine. Or thyroxine. And that's the inactive form of thyroid. And then you expect the body to convert it to the active form. But some people don't convert that very well. And he was one of those people. And so they altered his thyroid prescription so that he would be getting a little bit more support. And so these were really customized. And with that, they also went back and looked at all the other stuff that he had started because it looks good on paper. And, it might have been good in some patients, but they were able to stop about 12 other things he'd been on. And with that customization, he actually did great. And his cognitive decline resolved, and he was able to go back to his normal life. And I heard this case presented, and she actually presented several other cases that showed the same kind of precision and really dramatic improvement. And since my background is in the ICU, and I have seen a lot of patients come in from nursing homes with cognitive decline, and their quality of life is just it's just dismal many times. And they come in for their infections and pneumonia and urinary infections. And I was When I first started studying Dr. Bredesen's work, it was while I was still working in the ICU. And I just realized how much more impact and how much better people could be doing if we could implement this earlier on. And so I'm very excited about this approach. This just shows you kind of the scale of the types of things you can look at with genomics. We talked about some of the factors that are in the brain optimization panel, but they've got panels that are looking more at medical conditions. So there's a lot on osteoporosis, macular degeneration, melanoma, anesthesia risk, obesity, and weight loss. You can look at mental health disorders, things like anxiety and depression, ADHD, and there's some overlap. It's not like these are totally independent, but it just allows a level of precision that I don't think we've had before. So the other thing I wanted to talk about is this selling false hope? And I know there have been some recent articles that have really criticized this approach and saying, you know, this doesn't work, or you can't promise people are going to get better. This is just a part of aging and we should all accept it. And I want to caution people, because I agree, you don't want to be selling people false hope. But if, as a physician, you come to a patient and you tell them, there's nothing you can do, it's game over, I'm sorry, we don't have anything to offer you, then you put the patient into this kind of hopeless state where they just feel like they have no agency, no ability to impact what's going on. And if that's truly the case, then fine. But if there are some things that the patient could do and that they could participate in and be proactive in, and we don't share that, then I think we're sharing false hopelessness, which might be a little bit of a new concept, but I think this is an important thing to consider. And so I want to sit here in the realistic hope side of things to tell you there is a lot that is or that we can do, and now we just have to figure out how do we implement this. So this is all personalization. It's very actionable. It minimizes this trial and error. I think it improves our outcomes better than our standard of care. And just in case anybody is wondering about potential criticisms, people have wondered about Bredesen's work. Some people will say, well, it's not proven. Well, it's not proven to the level of big pharma studies because they don't have that kind of funding. But they have a case series of 100 patients that have shown that this works. And I think when you have 100 cases that defy what we think is the standard of care, we should look at that. They have a trial looking at 25 patients that is showing improvement. We have a trial that's in progress now that's randomized and placebo controlled, so that will be an even higher level of evidence. And it just takes time to get the funding for this because this isn't what's normally funded. I talked about, is this false hope? And I think, no, it's not. I think this is real hope, but it also needs to be, people need to understand that this requires patient engagement. This isn't just the physician prescribing something and you'll get better. This is a team approach. And that's why it's so important to have Laurel here, because she's so good at getting patients involved so that they can really change their own outcomes. And then people talk about the expense, and certainly supplements are expensive. These kinds of tests are expensive. They're not covered by insurance because this is outside of what we typically think of. But I showed you the cost of the conventional drugs, and they're talking about $26,000 a year, $32,000 a year, and they don't even help you get better. They just potentially cause brain bleeds and slow your progress down just slightly. And I think it's important to think about what's the expense of memory care and all these long-term care facilities, because that is astronomical. And when people talk about this protocol being very difficult, well, it is, but watching someone fall apart is also very, very difficult. And this is just a discussion about kind of the cost of doing nothing. A few months ago, I looked up, what does it actually cost to go into memory care in my area? And I live outside the DC metro area. And I looked at over 10 different centers, and the average was over $100,000 a year in memory care. So even if what you really did was to delay memory care by 6 months, which doesn't feel like what you want, but even if that's all you did, that's $50,000 worth of better life. So I show that as an example. And with that, I think I will stop and open things up for questions. We can cut the recording and then people can ask questions and go from there.